unknown origin of unknown origin. And goiter, when we are talking of abiotic, so they can have goiter. We also have skin changes, hyperpigmentation, ACTH, and melanocyte-stimulating hormone share same precursor molecule as the QMC, protein. And this usually appears in your elbows, knees, broken mucosa, and recent scars. Finally, vitiligo. I also have hypoglycemia. I have marked craving for salt and salty food. I have menstrual irregularities and changes in mood. Yes. This is a picture of when to consider adrenal insufficiency. GI symptoms or other autoimmune conditions, or history of brain radiation surgery. Now, between primary versus secondary adrenal insufficiency. In primary, aka addicts, cortisol due to adrenal gland, increased cortisol and increased ACTH, or like in secondary, where you have low cortisol due to pituitary or hypothalamus. Here, cortisol is down and your ACTH is either normal or down. This is secondary. Now, usually, what we do here, let me just tell you, when you come hypoglycemia, because one of the common causes of hypoglycemia is adrenal insufficiency. Having hypoglycemia is having weight loss, passing so much urine, to begin to suspect adrenal insufficiency. So they can have you regular weight loss and all that. But once they have those three things, hypoglycemia, large volume of urine, and weight loss, you screen them for addicts or adrenal insufficiency. So when you have gone down, you can now say this is addicts. Diagnosis. Well, we start with the detailed medical and family history plus physical examination. With special attention to any endocrine disorder. Of course, do your full blood count, yes. You may find anemia, eosinophilia, and related ESR, which are all non-specific really. Of course, your E and U creatinine is very important. This will show hyponatremia, hyperkalemia. To be very common MCQ question. What's your E and U picture will give in addicts? That's why sometimes when we come to review the patient, we just ask for E and U and see the electrolyte pattern before we do anything. So if you show hyponatremia, passing so much urine, hyperkalemia, hypercalcemia, elevated urea, blood sugar shows hypoglycemia, serum cortisol, aldosterone, and ACTH. Here you expect basal cortisol to be more than 580. This excludes the diagnosis. Undetectable cortisol is diagnostic. Don't do it as much as we should. And of course, you need to do your thyroid hormone profile because they may have thyroid disease to background. And you go on to do your anti-adrenal, and the first thing are negative. Plasma renin activity is increased. You need to do that. neurological investigations, abdominal X-ray, ultrasound scan, CT scan, even MRI. Calcium deposits may indicate bleeding into the gland or TB of the adrenal gland. And you can actually pick this in your abdominal X-ray. See calcium deposits on your adrenal glands. And sometimes this will not even give you, in some cases, you need to do what they call spiral CT to actually pick the problem with the adrenal gland itself. Treatment. Treatment is simple. If you endocrinology, if you lack your hormone, you will replace. If you have too much, you have block or will remove it if it's too much. So here, lacking cortisol, so we replace what hydrocortisone. So give you hydrocortisone 3 times daily, 10 mg on waking, 5 mg at noon, and 5 mg at 6 p.m. This is so because the cortisol production is highest in the morning, 6, 7, when you're waking up. The body is preparing for the day, so it's using enough cortisol to attack the day. And at after midnight, when you are going to sleep, you have the lowest amount of cortisol because you're preparing to go and sleep and relax. So you give the highest dose in the morning to cope with the stress of the day, and you give 5 mg noon and 5 mg at 6 p.m. Alternatively, you can use prednisone, 10 mg on waking and 1 to 2 mg at 6 p.m. Found out that most of the time we give up to 5 mg on waking and half of that at 6 p.m. Lastly, you may need to add a immunocorticoid replacement. Here we use fluorocortisone, which is given orally at a dose of 0.5 milligram to 0.1 milligram, that's 0.05 to 0.2 milligram daily. Most of the time we just give 0.1 milligram daily. This is difficult to find. I think the last person that prescribed this for one got it in Lagos, the second person was unable to get this around here. Diagnosing adrenal insufficiency. It's like the quick summary of the workup. Check morning serum cortisol. If it is less than 3.5, that's low. And you check ACTH. Anyway, don't worry yourself. I understand the new problem. Let me help you as a guide. But I don't want to get you confused because of the too many arrows. But if it is low, if it is intermediate, and you are thinking of secondary adrenal insufficiency and primary adrenal insufficiency, that's what we do. Treatments of primary and secondary. Primary, you just give your hydrocortisone plus hydrocortisone. Secondary, you give your hydrocortisone alone. You don't need the cortisone. But because we are talking about addictions, which is primary, your hydrocortisone and your glucocortisone. If this whole thing looks confusing, let me just break it down.
Everybody, let's start time.
If you, what we do, let me tell you what we do. If the patient comes and you're suspecting adrenal insufficiency, whether primary, secondary, or tertiary, first thing you do is you do a spot or a random cortisol assay. And if you do that and you're getting something, because they give you, each lab usually have their own range. If the value given by the lab is lower, the value you get is lower than you are worried. You say you do early morning, look at your early morning serum cortisol. When you expect the cortisol level to be highest, if it is still low, your patient has adrenal insufficiency. Now, whether it's primary or secondary, you may need to find it. And your best bet is to do your ACTH assay. The ACTH is normal or high. You know you are dealing with primary adrenal insufficiency. If it is low, you probably are dealing with a secondary cause of adrenal insufficiency. These results come late, so we don't even wait for the results because you can't even, I think, that will take usually before we get the results. So we just manage with hydrocortisone until we get other results to decide whether it's primary or secondary. Yes, monitoring of therapy. Don't give steroids and go to sleep, you must monitor. Have the clinical ways of monitoring. Then you have signs of your cortical excess, e.g. weight gain. You are giving patients steroids and start accumulating with gaining unnecessary weight, you should be worried. You want to tilt them from additives to pushes. Blood pressure, including postural change. Blood pressure is increasing and having marked postural drop, to be worried. Number 3, either edema or hypertension suggests excessive corticoid replacement, whereas postural hypotension and salt feeding suggest insufficient treatment. Chemically, you can also monitor your serum electrolytes, trying to normalize the potassium, sodium. You're looking for hypo or hypernatremia, hypohyperkalemia, hypohypercalcemia. Because whatever it is tells you whether you are under-treating or over-treating the patient. 2, you need to do your plasma running activity. This is elevated insufficient glucocortisone is given. Then there's what we do is cortisol Day4 to assess adequacy of treatment. Don't worry about that. We leave that for postgraduates. It's a curve you draw. And here, cortisol here. And you patient may need to increase their medication during period of stress, like illness. Accident causes them to become worse. This is called Addisonian crisis. Actually, Addison's is usually a worsening of adrenal insufficiency. This is called Addisonian crisis or acute adrenal insufficiency. This occurs in about 29% of patients. It may also develop in those on long-term oral glucocorticoids who suddenly stop taking their medication. It is also a concern in the setting of lymphedema coma. I wasn't given in that setting without glucocorticoids in precipitated crisis. That's why you're supposed to replace steroids before if you have issues. Symptoms of additional crisis include sudden penetrating pain in the lower abdomen, like what you have when you have acute abdomen. And then sometimes you have it appears as surgical emergency, but when you examine, you find that nothing is broken or torn inside. It's just chemical problems that are causing the pain. Sudden penetrating pain in the lower abdomen, even your diabetic emergencies, hyperglycemic emergencies can also present with abdominal pain that looks like acute abdomen. Now back and have pain in the back and also in the legs. There's severe vomiting, diarrhea, dehydration, low blood pressure, loss of consciousness, hypoglycemia, psychosis, lethargy, hypercalcemia, serious fever, and even AIDS. It's that serious. It's like the worsening of the normal signs and symptoms. Treatment. Cortisone injection. The primary treatment is an IV or IM injection of hydrocortisone. Usually we use the IV, it's faster, unless they are in shock and we cannot assess the veins. Fluid replacement, intravenous fluid, typically normal saline and 50% exposed water, especially when they are hypoglycemic. Given to manage low blood pressure and hypoglycemia. Of course, these patients must be hospitalized, and sometimes they will need to be kept in ICU. Monitoring and further treatment usually require hospitalization. Addressing underlying causes. If an infection triggered the crisis, antibiotics may be necessary. Each patient never to miss a dose and how to inject themselves. They should know how to double the dose of corticosteroids during febrile illness and to get medical attention if unable to take medication orally because of vomiting. They should have a needle syringe diluent and vial of hydrocortisone when traveling for emergencies, because they have an accident or something and they need to be attended to, they need to use it all day. They should be encouraged to wear a medic alert bracelet or necklace and always carry a steroid card. The card should alert emergency personnel about the need to inject 100 or 200, depending on how bad your patient is. At least 100 milligrams of hydrocortisone if its bearer is found severely injured or unable to answer questions. The card should also contain the name and telephone number of the patient's doctor and the telephone number of the nearest relative to consult. Complications. Adrenal crisis we mentioned before, life-threatening complications are caused cortisol will drop severely. Electrolyte imbalance, hyponatremia, hyperkalemia, hypercalcemia can lead to cardiac arrhythmias, muscle weakness, and respiratory failure. Osteoporosis, long-term glucocorticoid use can lead to bone loss and osteoporosis. That's one of the complications of using steroids for a long time. Prognosis: patients with Addison's disease can live a normal and healthy life with proper treatment and management. Untreated Addison's disease can lead to severe complications and even death. Thank you for your time. Questions? Questions? Big questions?
No questions. Questions?
There are no questions. I want to assume that if we all see patients with adrenal insufficiency, we can manage. At least diagnose and manage. The problem is that most of the time, you need to have a high sense of suspicion because first, the common investigation cortisol, they are not routine done here. You need an endocrine lab to attend to that. Secondly, sometimes you wonder the patient has his patient's obviously hypothyroid and the result comes normal, and you begin to wonder if the result is for the same patient you are seeing right in front of you. So you need to, and sometimes find, because when the patient gets the results and it's normal, they come and they give you all the classical symptoms of hypo or even hyperthyroidism, and the result says it's normal. The patient thinks it's not that is not the problem, but whereas from what the patient has presented to know, so what we tell them, okay, let's do a trial, take it for a few days and if you don't get better. Because the lab results, if you follow the processes, there are several processes. So during residency, you spend a full month in the lab doing the test yourself. So there are so many places that have human error. And because of that, you don't use the results alone. Like I tell my patient, you treat the patient, not the result. The result is the guide. It does not. And that's where a lot of our doctors do well abroad, because abroad they treat the result, not the patient. And something I'm staring obviously, and the result says it's not, you're on your own. But here we don't have the means of doing tests most of the time, so we need to narrow down to one or two. Your investigation, while you're waiting for the results, we need to even start teaching the patient, because the patient will get better. Now we talk about the results. So you must have the high sense of suspicion, and when you come, because it's life-threatening, it's not something you wait. And once you suspect, start your treatment. You can always stop if you feel, if you come for data, the patient is not getting better. You can always stop. The treatment will not kill the patient. But if you don't act, patient can go down and eventually lose the patient. Okay, thank you very much.
Thank you, sir. Thank you, mom. Thank you, everybody.
But we don't have the idea. walk back here like this. I won't have. I'll try. No, they ever walk.
Next person we
You My baby. How are you? When I go come greet you now?
I be adult.
And when I go come greet you?
Wetin you go bring us the so you go bring another bread.
She no go. I say. It go be like say she see the day. She see the steak. Are you not supposed to invite us over?
Because they come and bring banana bread.
Okay, you buy it. I want to do tomorrow. Okay. Okay. I do my
Ajuma.
No, now I don't do the one where you Okay, you want tomorrow? On 500 on.
I want to say I know I'm not a fan of banana bread.
That one's like cake, or you know?
It's not like cake to me. It's not like cake. As far as you can do banana bread, then what can you not do cake?
That cake, mixing. The one like
so now banana bread.
I have to mix it.
Banana bread is not stressful.
That time, it could be like that. Oh, I don't like that embarrassment. That time, I just felt somehow. That time, now people to make me give it. What do you put for your mouth? So.
Why you don't rub this one?
Now let me know.
Why do you rub this in your mouth? I've been on my mouth since now.
She just rubbed it to her.
She's once you know because you know blend. Just the line. I just rub it like before class.
It's making your lip juicy.
Juicy. Hey, for me.
So now you open like this. Okay, shame.
Why you open like that?
It's not me. It's not me. Stop. Who made you to lie on my head?
This thing you enjoy it too much. Why do you go buy blocks? I wanted it to melt. Where?
I was like, you buy.
Oh, I don't know. That's it. That is cool.
Don't show Lily.
It's like if I buy some place, I will just behind.
I don't like it.
So,
Yeah.
I need to
Follow the phone.
Yes,
Why do you one day like this? You too blessed.
that's okay. As the man right?
What is it?
So this one everybody's coming inside.
I see that.
I see the man is here. Rose! So if there's spoon, what will you do? Hey, what's that there? So I beg you, fast. Fast, you should not waste time. What are you not waiting for? I'm sure, no, wait, no.
It's 8 o'clock. I'm not ready.
Why do you guys go be serious in your uniform? 8 o'clock class today. Since the magazine they already raised
Good afternoon. How is everyone? I'm talking of who will be speaking for the first time. Okay. Ojib Olaiton Rafiu. I'm a nephrologist, the chief production physician. I'll be taking some topics in nephrology. Okay? You should have had this topic, but I was out of town. Okay, so I requested for extra slots that I'm taking today. So the topic is the nephrotic syndrome. And I'll be following this outline. Introduction, epidemiology, pathophysiology, scientific, specific entities, okay, clinical vision, complication, management, and prognosis. Okay? So, what is nephrotic syndrome? Yeah, in nephrology, when there is glomerular injury, there are ways you can prevent. And you can prevent with like asymptomatic urinary abnormality. Okay? You can prevent with hematuria. You can prevent with nephritic syndrome. Have I given you a lecture of glomerulonephritis? Yes, sir. I talked about A2O2P. Yes, sir. Okay, you can also prevent with nephrotic syndrome. Okay? So these are the various ways you can prevent. So I'll give you a lecture on nephrotic syndrome and give you a lecture on nephrotic syndrome. So nephrotic syndrome, like the name implies, okay, the constellation of symptoms, okay, and it is defined as presence of proteinuria that is equal to or greater than 3.5 grams per 1.7 centimeter square body surface area in 24 hours. That's number one. Followed by what? Hypoalbuminemia. Followed by what? Generalized edema, which is referred to as anasaka. Followed by hyperlipidemia. Lipiduria. What is lipiduria? Passage of lipid in the urine, isn't it? Okay. Lipiduria, with or without hypercoagulability. So these are the components of nephrotic syndrome as against nephritic syndrome. Okay, keep there. Now, because I would like to say this in MCQ, so you know the components. Nephrotic syndrome, we have A2O2P. In nephrotic syndrome, you have this constellation. Is it fair? It's good. I will break it down. Yeah, okay. Now, podocyte, which is the visceral epithelial cell, the glomerular basement membrane, and the endothelial look at the key structure. Now, there are some structure cells in the kidney that do not take part in filtration process. We call messenger cells. They are like cytoskeleton. They attach all the other cells together, but they don't take part in filtration. We call them the messenger cell. Can you see? Okay. So the cell that makes up the resident glomerular cell are parietal epithelial cell, visceral epithelial cell, endothelial cell, and messenger cell. But out of all these cells, the parietal epithelial cell does not take part in filtration. That way, the messenger cell does not take part in filtration. Filtration occurs across the endothelium, basement membrane, and the visceral epithelial cell. Is that clear? Let's move. Now, this is to simplify it. This one you are looking at here is the parietal epithelial cell. This is the urinary space. This is the visceral epithelial cell that has food processing. This cell is called podocyte. This is the glomerular basement membrane. This is the endothelial cell. This is the capillary lumen where blood is flowing. So filtration occurs. I'm blocking here. I'm not going to stand there. I'm going to block it. Okay, sorry. But am I blocking anybody now?
Yes, sir.
Okay. So filtration occurs across these three structures: the endothelial cell, the basement membrane, the visceral epithelial cell. So this blood is filtered across these three structures to form the urine. Do you get it? What did you know? What did you get? Look at the explanation. Now what? Eh? What's that one? There's a blood vessel from the lumen through this structure into the urinary space. Now look at this cell now. This is the messenger cell, isn't it? And the messenger cell does not take part in filtration, but does a supporting structure. So blood here gets filtered across this filtration barrier to form the urine in the urinary space. That's how urine is formed. Okay, good. Let's move ahead. Now, in nephrotic syndrome, I listed like about 3 features, isn't it? The most important feature of the nephrotic syndrome is what? Proteinuria. Every other feature of the nephrotic syndrome is consequence of the proteinuria. Okay, that's what I'm saying. Okay. Okay, the proteinuria in nephrotic syndrome is due to altered permeability of the glomerular filtration barrier, which I just explained to you. That is glomerular basement membrane, the podocyte, the podocyte, and the endothelium that has the diaphragm. Okay, for protein. So that filtration barrier, what is the pathology in nephrotic syndrome is the affectation of that, destruction of that filtration barrier that allow protein to leak. And leaking that's not the protein in your urine. The protein will contract in the blood. While the excess water, exogenous waste, and it's actually filtered and is excreted. But when there is perturbation of that filtration barrier, protein start to leak. So that's what happens in the urine. So why is protein leaking? Under the lipid that are supposed to have been broken down, then accumulate in the blood, so resulting in what? Hyperlipidemia. Is that there? Yeah. Okay. Now, okay. Okay, so this is the same. The police not to have the low density cholesterol is high. The patient is very disease, very low density cholesterol, and triglycerides are also elevated. So that's all right. The hyperlipidemia can accelerate atherosclerosis and lead to progression of renal disease. Okay? Good. So let me to the next slide. When do they have hypercoagulability? In the blood, there's what I refer to as antitrophin-3. You must have heard of it before. That antitrophin-3 prevents thrombus formation within the blood vessel. But unfortunately, that antitrophin-3 is a protein. So it is also lost together with protein in the urine. So there is decreased antitrophin-3 activity in the blood. So that will result in hypercoagulability. You get it? Yeah. There are also some other proteins. We refer to as protein C and protein S. These are natural fibrinolytic proteins. They break down clots in circulation. Unfortunately, they are also proteins. They are also lost in the urine. So the level of antitrophin-3, protein C, protein S in people with obesity is low. Resultantly, there is hypercoagulability. Because what the agent of the broken down the thrombus or pressure performing, they are lost in the urine. Okay. The consequence of hypercoagulability include peripheral venous and arterial thrombosis, renal venous thrombosis, pulmonary embolism, and stroke. So these are some of the complications of nephrotic syndrome. Okay? So what I don't have established complication of this syndrome is that iron resistant hypochromic microcytic anemia. Because when there's iron deficient anemia, what do you have? You have microcytic hypochromic anemia. If you give iron, it will correct it. But in nephrotic syndrome, it is not iron that is being 1.7 kilometers carbon surface area of protein in 24 hours. Total serum protein and albumin will be reduced. So that's the situation you are going to do. You do that protein and albumin. Okay? If you do fasting lipid profile, what are you going to see? You see hyperlipidemia. If you do clotting profile, you show evidence of hypercoagulability. You can do electrolyte urea and creatinine, calcium phosphate rate. It can either be normal or it can be deranged. Then you can see for specific infection. When what are spreading? HIV, malaria, syphilis, epilepsy. You can look at all these things from drugs and pregnant, like heroin, minimal shape. Am I dealing with mephinos nephropathy? Am I dealing with pulmonary bronchitis? Am I dealing with focal segmental glomerulosclerosis? Because the management of these entities is sort of different. The easiest one to manage is chain disease. Okay? The people that have amyloidosis, okay, you don't even do, but when you do biopsy, it's a very important can use biopsy. You can biopsy the rectum. You can biopsy adrenal fat. You can biopsy salivary gland. What is called Congo red. And what you are going to see is apple green bioelectricity under polarized light in amyloidosis. This is a focal question both in undergraduate exam as well as postgraduate exam, both in national exam as well as international exam. When you take anything with Congo red, and you are seeing a blue apple green bioelectricity under polarized light, it is amyloidosis. Okay? Yeah. So how do you think there is general treatment? Okay? There is general treatment, there is specific treatment. General treatment, you want to go for the symptoms. For instance, the person is having edema. What you want to try to reduce the excess by giving that, get it? Okay, yeah. Then another way to also reduce the extent of protein loss is reduce the dietary protein. Okay? You get? Then the another picture of the body apart from eating like that, the person is having proteinuria. Sorry, I talked about that was people that was talking. You keep directing. You can carry out and water with restrictions. But for proteinuria, how do you reduce proteinuria? You can reduce dietary protein, or you can keep what we call peritoneal adenosis. 50% of patients have relapse of nephrotic syndrome after withdrawal of drug. So somebody that does remission, by the time I stop steroid, the patient can start again. Okay? So because the patient has relapsed. Patients that do not respond to steroid therapy, so patients that have up to 3 relapses a year are called frequent relapsers. Patients that do not respond to steroid therapy are said to be steroid resistant. Okay? So if the person is not responding to steroid, okay, what are the alternative agents? Okay?